Andy Vincent from the education team, and I'd like to start our meeting by acknowledging the traditional custodians of the lands that we all live and work on. I'm on Darkinjung land and pay my respects to elders past, present and emerging. As always, just a reminder that we are recording this session today. And if you do have any questions, please feel free to put them into the chat, but otherwise there's going to be plenty of time for interaction. And I'm going to be putting a Slido evaluation link into the chat at the end of the session, so please do complete that for us. And with that, I'd like to hand over to Jessica. Thank you so much.
Thank you, everyone, and thank you for joining me this morning. So, as Sandy said, I'm Dr. Jessica Murphy. I'm a GP with special interest in intellectual disability health, and I work at the Complex Care Service, which is a service and specialist intellectual disability service run by the Centre for Disability Studies. We're a statewide service, and we see people for comprehensive health assessments from the age of 15 upwards to identify any unmet health needs and to kind of liaise back with GPs about how to kind of, get things moving along for any sort of tricky areas of their health. So that's a bit about me. I would also like to acknowledge the traditional owners of the land on which we meet today and pay my respect to elders past and present. And I'm joining you from the country of the Wangal people of the Eora Nation. So today, what I'm going to try and cover are these things on the slide here. So a bit about why people with intellectual disability find this area quite tricky to navigate. A bit about how we go about checking people's capacity to consent for using contraceptives. A bit of the practicalities around prescribing, screening issues, when we use contraception for symptom control, when we use contraception for behaviours of concern, and then just some less sort of other considerations. I'm probably not going to go into specific sort of genetic conditions or medical conditions because the individual circumstances just vary too widely to cover in an hour's presentation. So I'm kind of going to cover a bit more about kind of practicalities, logistics, and common tricky things that come up. And I'm more than happy to take questions as we go along, or we can save them till the end. I'm pretty flexible and easy. You can always put comments in the chat and we can unpack them, whatever you feel appropriate. Okay, so let's begin. So why do people with intellectual disability find it difficult to access sexual health care? And I think that's because there's quite a few systemic and personal barriers. If we start with the systemic barriers, there's still a lot of prejudice and assumptions around the fact that people with intellectual disability aren't sexually active, and therefore it's generally not kind of brought up with them or discussed with them at appointments. And I think there's not easy access to services out there to facilitate that. There's also the lack of education for healthcare professionals about intellectual disability health in general. Sort of studies have shown that in Australian medical schools, the average time spent on intellectual disability healthcare is around 3 hours, which is obviously very, very poor, and needs to be improved. And that's not just with sexual health, that's just in general. Medicare, I'm sure we've all got opinions about Medicare billing. And my opinion is I just don't think the Medicare billing is adequate for the complexity that these consultations require and the time that we need to spend. And therefore, I think it disincentivizes a lot of us from providing that level of care. From a personal level, from the individuals, I think there's definitely a lack of sexual health education that these people receive. And I think that links back into that first point about that kind of assumption that they won't be sexually active or they potentially shouldn't be. Lots of people with intellectual disability do have varying communication issues, and that can make it difficult for them to convey what they need from a consultation or to bring the topic up, and could be making it difficult for us to facilitate that as well. And I'll talk a bit about ways we can try and make that a bit easier. These people tend to depend heavily on their carers or family to attend appointments. And that can be a barrier in itself because it means that they've got little privacy and accessing accessing support, and they may not want to bring these topics up in front of their family member, but may not have an opportunity to without them, which can impact how they go about things. They often have fear or embarrassment about discussing this. I think that's pretty common amongst a lot of people. You get a lot of young people coming in to see us, don't you, who feel a bit embarrassed about asking about things. So I think that's the same for this population. And we have to be aware that there are definitely increased rates of sexual abuse and trauma in this patient population, which may in of itself prevent them from wanting to discuss it or to sort of reopen any trauma from their past. We'll talk a bit more about that later on. So when I was thinking about this topic and how broad it is, I was thinking, where do we start with this? And I thought probably it was easy to break it down into why do we use contraception for people with intellectual disability? And then we can kind of go through then in order. So of course we may use it as contraception as intended. There's a portion of what we use it for is symptom control, so particularly dysmenorrhea, menorrhagia, people with epilepsy. Sometimes seizure control can worsen cyclically. And then what's a bit different in this population compared to others is that we sometimes need to use this because of behaviours of concern. So worsening behaviours around the time of the period, and we may want to then suppress the menstrual cycle to manage behaviours. And I'll talk about that later on. So if we start with contraception and using contraception as a contraceptive, and how do we go about navigating this as a GP if somebody does come into us and asks this question, or a family member does? I think the first thing that we need to do as GPs is ask about it. As I said before, there's often a presumption that people with intellectual disability aren't sexually active. And therefore, if we're not inquiring about it, these people may be having sex in an unsafe manner or risking unintended pregnancies. And I think an ideal opportunity to ask them if they are sexually active is around the annual health assessment time. As you know, we should be doing an annual health assessment for all of our patients with intellectual disability. Medication reviews might be another opportunity. If we're doing those 3 monthly medication reviews, we can say, are you on a contraceptive? And I think these conversations are probably going to be more relevant for the mild to moderate end of the intellectual disability spectrum. But it's really, I suppose, a starting point of discussing it is finding out what that person's understanding is about sex and pregnancy risk. And that level of understanding or ability to learn about that will obviously vary very greatly depending on their level of intellectual disability. Hopefully these patients will be patients that you're familiar with, as they'll be your regular patients, and you may already have some understanding of how they communicate and what they normally understand, and will therefore be able to quite easily get into a discussion with them. It's probably much more tricky if they're a new patient to you and you're starting from scratch. How do we do that then? How do we talk about it? Well, there are lots and lots of easy read resources out there to facilitate this. Sorry, these images, I've just realized, they're a little bit blurry on the screen. But there's these top 3 resources here on the left hand side: Family Planning New South Wales, the Council for Intellectual Disability, and I found one online called the sexualhealthhub.co.uk. They've all got really good resources about learning about sex, about safe sex, about appropriate masturbation, about what healthy relationships look like. The one from the Council for Intellectual Disability goes into how to choose my contraception. And the Sexual Health Hub has lots of fact sheets about the individual types of contraceptions and also sexually transmitted infections. So there's definitely heaps and heaps of resources out there that you can use with your patients. But I think what's important to facilitate this is to learn how does that patient usually communicate? Do they use easy read resources? Do they use another visual schema? Are they more of an auditory kind of listening, feeding back type of person? And what does that look like for them? Because that is going to vary very widely, from person to person, and it's definitely not one size fits all. And I think that's where we probably as GPs need to rope in support for these discussions. So, if this person lives at home with their family member, is there somebody in their family that they trust enough that we can bring them in to help us to facilitate these discussions? If they have a wider support team, like an occupational therapist, a speech therapist, a behaviour support practitioner, it would be ideal to rope them into this and to get them to do a bit of groundwork before the consults, because a lot of this education is going to take time to go over, and it's probably not something that we're going to be able to facilitate a full sex education teaching session, let's face it. So a bit of that groundwork probably needs to be done with the patient in advance, and then we can kind of come in and clarify what their understanding is so that we can assess their ability to consent about sex and about contraception and what it's for and the purpose of it. Of course, this is going to be hard work as in a GP setting. And that's where our reasonable adjustments have to come into play. We need to be having long appointments for these patients so that we can facilitate their communication styles. I think this would need to be done over several appointments so that we can chunk information down and then check their understanding each time. And I would definitely make the use of sort of written or pictorial information in a format that they can understand, like the easy read, so that they can take that information away and digest it in their own time and then bring that back to us, again, with the support of their support network, if appropriate. Now, what if they can't consent? I think when I was going through my slides last night, I kind of thought this is probably in the wrong section of this presentation, because if they can't consent, if they don't have the capacity to consent to having a contraceptive, it probably raises the question of, do they have the capacity to consent for sex, and the issues around safe sex. So I think this might be more applicable when you're using contraceptives in a different way. But anyway, I'll put it in here. So if the patient needs medication and they can't consent, then ideally we would always try to seek a supported decision making through their person responsible, which may be their family member, it may be a parent, a sibling. It may be a carer that they've nominated as their person responsible, or a friend. If there is nobody that is suitable for that role, or if it's deemed that their situation is kind of become too complex for a person responsible to be in that position, there may be allegations of neglect or abuse or whatever, then they may need a legally appointed guardian, and that decision is made through the NCAP process, and there's a schema on the page there. There's also a separate branch of that for financial decisions. So there's a medical and lifestyle, I can't remember the wording, medical and lifestyle branch of the guardian, and then there's a financial manager branch of it, which are two separate roles. Now, the exception for this is for restrictive practices, when restrictive practices have to be decided by a legally appointed guardian. And I'll come back to restrictive practices towards the back end of the presentation. So let's say that we've had our consultation with the patient. We've gathered that they do have capacity to consent, and we do want to use a contraceptive. What do we use? Now, of course, a lot of this is going to be decided on medical factors, so risk factors and what other medications they're on. But we have to kind of think about, logistically what that looks like. So, if we're prescribing a pill, we need to figure out, how do they normally take their medication and how do they normally cope with that if they're on medications. I think we underestimate the complexities of taking a pill, because there's obviously, you've got your 21 on a standard pill pack, you've got your 21 days of your active pills, and then your 7 days of your sugar pills. And then what if you miss a pill? What do you do if you miss a pill? Do you take one? What if you have, can you run them back to back? And then what if you do have a breakthrough bleed? And when we're explaining that to patients without an intellectual disability, they can even get a little bit tripped up by that sometimes. So we need to be aware that our explaining needs to be extremely kind of, explicitly open and easy to understand. A good example of this is not relating to contraception, but I know a lady with an intellectual disability who is very capable. I would say she's got a mild to moderate level of intellectual disability. She's very capable. She's a public speaker, and she's, quite independent. She went to her GP, and they prescribed a medication, and the advice was to take half a tablet daily. But she went to the chemist. Well, her mum went to the chemist with the prescription, and the chemist gave the medication, but they were full solid tablets. And she needed to take half a day. So her mum clicked onto this and asked, well, how do we cut them? And the chemist provided a medication cutter and explained to mum, so that mum could take that back to her and cut her pills up for her, so that she took half a tablet a day. And the patient herself tells this story when she does her speeches, because she makes the point of that if her mum hadn't have asked the pharmacist that, she would have received full tablets, and she wouldn't have known that she needed to cut them in half, and therefore she would have been taking the wrong dose. So things that seem quite straightforward actually need to be fully explained. So therefore, when we're looking at a pill, how do we make that easier? Again, can we use some easy read resources to help explain the regime? Could we even work with their carer or their speech therapist to design their own easy read aid memoir for taking the pill? Is it better to put it in a Webster pack, so there's little room for administrating error? Sometimes it may be more appropriate to just omit the sugar pills entirely, although the problem with that is then often people will end up having an unscheduled bleed or a breakthrough bleed at some point. So again, how do we navigate that? I think we need to remember, if we're prescribing a progesterone only pill, there's that very tight window of taking it. There's a 3-hour window with the more traditional progesterone only pills. Therefore, I'd probably choose something like Slinder, which has got more of a standard once a day dosing window, so we can avoid errors with taking it at the same time each day. And we, of course, need to just be careful that if we're prescribing pills, that we're not interacting with other meds. A lot of these people have epilepsy, so we need to be careful that we're not inhibiting their anti-epileptics. Ultimately, for this population, LARC options are probably going to be better. So, a Mirena or a Kyleena is probably ideal in the sense of it's got a very good bleeding profile. It's, you can leave them in for 8 years. Implanon, again, is another option, but the problem with Implanon, in my experience, is that a lot of people get a lot more erratic bleeding, and some people get sort of prolonged spotting. And for someone with an intellectual disability, that might be more distressing than not. So I think caution, but for some people, it might be fine. And then, of course, there's the Depo-Provera. However, I think we just need to be careful with bone density issues with Depo-Provera, particularly because a lot of people with intellectual disability do have other risk factors for osteoporosis, given that they're often more sedentary, especially if they're kind of wheelchair bound. So we just need to be careful again about the medical aspects of Depo. And of course, we need to consider side effect profiles as we do with any other patient. So, if this patient already has mood issues, then choosing pills or options that are less likely to disrupt that. If they suffer with acne, again, we're not going to probably want to put them on the Depo if they're already overweight. So I think a lot of those medical factors are exactly the same as when we prescribe for the average patient population. I think what changes in this population is more the logistics and that understanding around it, and how we discuss that. I also thought I'd put in a slide about men's health, because I think men kind of get a bit overlooked in this topic. A lot of it's to do with women's health. But I think we have to realise that men with intellectual disability also have sexual health needs, that are quite probably a little bit different to women. Again, it comes back to good sex education. You know, do they understand how to properly put on a condom? Are they aware that they need to use a condom when they're having sex? And also a bit about masturbation. A lot of men with intellectual disability will masturbate as normal, but will often have some lack of understanding of how to masturbate appropriately, in the sense that, especially kind of as the intellectual disability gets a bit more severe, you're talking to that moderate to severe range, you may find that people are masturbating out in the open around other people or in public. And again, it's about educating them about when and where is appropriate to masturbate. And I think the people that are best to help with that are behaviour support practitioners, and support workers. Often they can redirect, when they see that behaviour, they can redirect the person to their bedroom, for example, if they're living in a supported independent living accommodation. They can redirect them to the bedroom and say, you know, this is where it's safe to masturbate, or where it's appropriate to masturbate. So again, I think we need to be aware of that. Not that I think it's necessarily a GP role to be involved in that, but I think it's being aware that that's a pretty commonplace thing that happens, and that doesn't necessarily mean that they have behaviours of concern that need medicating. Maybe they just need some education and support. I think the other thing that we need to be aware of, is, I mean, we are aware of, but I think just kind of need to remember for this population, is that there will be men that are, you know, are gay and will want to have sex with other men. And again, educating around the risks of sexually transmitted diseases, and thinking about, you know, is this something that they would benefit from being on PrEP, especially if they're having lots of casual sex in the community. We've got a patient on our books at the moment who does quite frequently kind of go and have casual sex, and he's pretty knowledgeable that he should be having regular sort of 3-monthly sexual health checks. He takes himself off to the sexual health centre for his screening, which is really good. But again, would PrEP be something that's appropriate? And again, discussing that would go back to that original slide that we spoke of before. And nowadays we've also got DoxyPep as well, which is an on-demand sort of antibiotic aiming to reduce the rates of STIs. So is that something that we, you know, we could look into? And I think the other thing as well is that another thing to be aware of is that a lot of men, not a lot, but some men with intellectual disability will visit sex workers because they may have difficulties forming relationships, and they still have sexual needs that need to be fulfilled. So again, having a chat with them about that, you know, are they aware of any of the risks? Are they taking adequate protection when they're visiting sex workers, and making sure that they're getting their 3-monthly STI screening done appropriately? And that kind of brings me on to screening, really. I think when we're having these conversations, we need to think about screening. And again, I think screening is something, sexual health screening is something that's done quite poorly in this population in general. So I think, again, as part of our education is about STIs. And again, there's lots of easy read resources out there about different STIs. And like anyone else, they should be having 3-monthly screenings if they're having unprotected sex, or if they're having casual sex, or we're not sure. I think the annual health check and the medication reviews are also good opportunities to check that vaccinations are up to date. So it would be ideal to make sure people are vaccinated for Hep A and B. When I sort of first started, but recently I've been looking into sort of the recommendations around Hep A, and I kind of had, I had a poor understanding of why we should be vaccinating for Hep A as well. But it is actually recommended in the Australian Immunisations Handbook for people living in supported independent living accommodation settings. And given that we have got a combination vaccine available, it makes sense to just kind of do it all together. HPV vaccines, a lot of these people may not have attended sort of mainstream schooling. If they're of that older generation, HPV vaccination is relatively new, right? So it may not have been a thing when they were younger. So again, it may be an opportunity that we catch people up with this, or if we have got young people, just making sure that they have received these, because usually they are provided by school and we don't get involved. And also thinking about our men who have sex with men population, thinking about Mpox vaccination, which again is relatively new for us. In terms of screening, again, this is something that is very poorly done. And I think it's more because of, with cervical screening, it's more, again, assumptions that people don't need cervical screening because they are going to be low risk. And with breast screening, I think it's because it's uncomfortable and people find it difficult. Talking about cervical screening, yes, a lot of our patients are low risk and a lot of our patients aren't sexually active. However, some will be, and so we should be offering it. And of those that aren't sexually active by choice, there will be a portion of that population that will have been sexually abused. And we may not know that, so they may not disclose that. They may not be able to disclose that if they can't communicate. Their family members may not be aware of that. Carers may not be aware of that. And therefore, if we're not offering screening, we potentially have a subset of women who've been exposed to HPV and we won't know about it. And we could potentially be missing some cervical cancers. So I'm strongly of the opinion that we should be offering cervical screening to all of our women. And when I say offering, I think just having the discussion with their carers, with their family members, with the person themselves, explaining the various methods. We now have self-collect screening, which makes it much easier, much less invasive. It can be done with the person that supports them, for example. Obviously, we need to be careful about consent, about who takes it. But I think just having the conversation, if at the end of the day the person or the family member declines consent, then that's great, that's their decision. But I think we should at least be opening the conversation and offering it. And there's some really great resources out there now about cervical screening. So on the left-hand side, the top two pictures, that's taken from the loss of where it is, the government page about screening. I can't remember what it's called now. Someone might help me out. Sorry, that's really bad. But they're on that website. If you just have a look for it, they're both easy read resources. They go into the process of taking a cervical screen, both in the old-fashioned way with the speculum and the self-collect way. And then there's also recently been a film produced called Screen Me about cervical screening for people with disability. It's a short film that features people with disability learning about cervical screening. And this was shot with a company called Bus Stop Films that is quite involved in involving people with disability in filming and producing and things. So that's a really good resource as well. And then I think, again, for men, just thinking about educating about testicular and prostate health. So again, inquiring about symptoms. We might need to give some education to patients about how to self-check. So I remember I've got a patient with intellectual disability who she's in her 40s, and she came to me and said, I want to know about how to check my breasts, because nobody had ever explained to her about breast screening or how to self-examine. So I, did an examination for her, talked her through it, and then gave her some easy read so that she could take that home and digest it further. Okay, so now moving on to a bit about symptom management. So the reason I think this is important to discuss is that I think a lot of people put up with horrible symptoms and don't ask about it. And I think for people without intellectual disability, if you're having terrible menorrhagia and dysmenorrhea, you probably are going to ask about it if it's really impacting your life. But for some of these people that I've seen in clinic, they're having symptoms where they're in horrible pain and they're actually taken to bed for 2 or 3 days during their period, and they're just using Panadol. And it's like nobody's kind of thought to bring that up. And I think that's probably that the family members just deal with it and don't think that that could be remedied in any way. And I think that's really sad because, as I said, I think other women wouldn't put up with those symptoms. So again, I think when we do our health assessment, asking, are they managing their periods? Like, are they comfortable during their periods? If they're just using Panadol alone, can we add in other analgesic options? And I think I've put data gathering there because I think it's important to get the carers or the family members to gather data about how it's impacting them. What happens? Is it that they take to bed? Is it every single month? Is some months worse than others? And how do they manage it? And then we can get a fuller picture. Of course, we need to, as ever, consider all of the medical issues and the side effects and whether there's any other interactions. But from a very simple point of view, can we consider, if we don't need contraception, can we consider some other non-contraceptive options? So again, if they're not, there's no contraindications, can they use some ibuprofen instead of just Panadol alone? Because often NSAIDs work better. And I actually really like the use of tranexamic acid for heavy menstrual bleeding. It actually works quite well, but we just need to be careful. There is a stroke risk with tranexamic acid, so you need to only take it for a maximum of 4 days. So again, that kind of goes back to our first slide about how we educate that, who would be responsible for overseeing that. Are they capable of managing that themselves? But if it's used appropriately, I actually think tranexamic acid works really well. Ultimately, then we might decide to prescribe some contraception to manage their symptoms. And then I think it's really important that if we are prescribing contraception, that we're reviewing it regularly, so we can review, is it working? Again, going back to that data gathering, how has it changed things? Are there any side effects? And the reason I keep banging on about data gathering is that often these patients may not live alone. They may not have the ability to understand if something has changed and how that has changed and what side effects they may be experiencing. So that kind of collateral history from a carer or a family member or a support worker is going to be crucial so that they can observe the before and after effects. And therefore, some of this is about educating the support workers as well about what side effects may be. And a really easy way to do that, especially if they live in a supported independent living accommodation, is to print off a CMI leaflet so that they can put it in their folder where their medications live, so that if there are side effects, the support workers can see, oh yeah, that's actually a side effect of this medication. And they're actually encouraged to do that as support workers in these organisations. There are, of course, logistical considerations with LARCs. If we're fitting a Mirena or an Implanon, they actually might need sedation for that if they're scared of medical procedures, or if they're not capable of sitting still, or if they've got behaviours of concern. And I think it's really important to remember that if we are doing sedation for any of these patients for any reason, whether that be a dental check, whether it be a procedure to have a scan done or have a LARC fitted, it's a really good opportunity to get other screenings done at the same time. A lot of our patients have difficult behaviours of concern which prevent them from having medical examinations done, and often they go years and years and years without having any screening done, even despite being on medications that need screening. So it's really good if they go and have a dental exam and they're being put under, if we can provide forms for blood tests, possibly even for a cervical screen, and if you give that with the patient, oftentimes the people doing the sedation can facilitate getting them done at the same time. So I know, for example, the big dental hospitals. So in Sydney, we've got Sydney Dental Hospital, we've got Westmead Dental Hospital that have special needs clinics. They will often try to get other things done at the same time. But in order to do that, they need the referrals. So it's a really good opportunity for us as GPs to give those referrals in advance. The family members and carers can keep them together with all their other documents. And then when the time comes, they can take them with them. Unfortunately, access to sedation models is scarce and is a real problem for this population, because a lot of them do need sedation to get medical things done, and unfortunately there's not many pathways that exist to do that. Oftentimes we're having to navigate it through our local hospitals, which can be really, really complex. And I think if you've got somebody like that who you think needs stuff done because they just cannot sit down and be examined, then I would probably be referring on to your local specialist ID health team, who can try to troubleshoot and facilitate that for you. But it's very, very difficult. And, even though we're one of those teams, we still find that probably one of the most difficult things to kind of logistically organize. Okay, so the last kind of section I wanted to talk about was when we use contraceptives to control behaviours of concern. So if any of you are unfamiliar with this term, so a behaviour of concern is defined as a behavioural response that creates a risk to the safety or well-being of the person and those around them. And behaviours of concern can be secondary to underlying physical or mental health problems. So because oftentimes people with intellectual disability can't communicate effectively how they're feeling, oftentimes it will come out as a behaviour. So things like pain can often be, can be driven, the behaviours can be driven by pain, they can be driven by infections, they can be driven by trauma or mental health conditions, but oftentimes it's outwardly perceived as a behavioural thing. So examples can be things like aggression, property damage, sexualized behaviours, sometimes just purely verbal aggression. But this can cause a real problem for the safety of the person and those around them, and that's why it becomes a concern. And I suppose when we're getting to this level, oftentimes these patients tend to be kind of from the moderate intellectual disability upwards of the scale, and it's unusual for people with mild intellectual disability to display behaviours of concern, but it's not, it still happens, but it's much more common in that more severe end. So in general, when we have behaviours of concern, we should start with a non-pharmacological approach to management. Again, data collection is absolutely key here. We need to know what are the behaviours, what circumstances do they arise in, how frequent is it, are there any apparent triggers, what happens before, during and after an episode, how is it currently being managed, what's been tried before and what's not helped. The more information we can get, the better we can start to tackle it. And as I've said, we should try non-pharmacological strategies first. So absolutely key here is positive behaviour support. So ideally, these people should be linked in with a behaviour support practitioner, possibly an occupational therapist with skills in mental health, and also possibly speech therapy to look at communication techniques when these behaviours occur. A lot of these will be obviously provided through NDIS funding. I suppose if they're waiting for funding, we could always look at, can we provide like a GP management plan for the interim just to get a couple of sessions under the belt, if that's something affordable, because often they'll have a gap fee. But I suppose one of the key things is that the support workers, family members, people involved are having a consistent approach to those behaviours. And oftentimes with really good behavioural strategies, we can minimise or manage the behaviours of concern before we even get to the medication stage. But unfortunately for some people, we will need to use medication because the behaviours are of such intensity or frequency that there's no other option. Just going to have a quick drink because my voice is going a little bit croaky. So when we prescribe medication with the pure intention of managing behaviours of concern, we call this a restrictive practice. So a restrictive practice is any practice that or intervention that limits a person's human rights or freedom of movement, as per the NDIS Act 2013. And when we're using medications, that classes as a chemical restraint. There are other types of restrictive practices. So there's mechanical, which is use of equipment to limit people's movement. Physical restraint, which is obviously physically holding people. Seclusion, which obviously is putting people in a room on their own. And then environmental, which could be, for example, locking away the fridge so that they can't go and have access to snacks, or locking cupboards so they can't access things that might harm them, for example. So what, in terms of restrictive practices, the NDIS is very clear that of how restrictive practices are regulated. And this is taken from the NDIS Restrictive Practices Guide. So they have to be clearly identified in a behaviour support plan. They have to be regulated with an authorisation process as per the state in which they're dwelling. They need to be used as a last resort in response to risk of harm, after we've explored other strategies, as I've just talked about. It should be the least restrictive response. It should reduce the risk of harm to the person or to others. It should be in proportion to the potential side effects or negative consequences of the medication or other restraint. And it should be used for the shortest possible time, which clearly means that we should be reviewing these medications regularly. Now, the most common medication for this is psychotropics, which obviously is not our topic today, but contraceptives are sometimes used in this manner, and that's why I thought it was relevant. And why is it relevant? Sorry, before I move on to that, if the person cannot provide their own consent, then it has to be required, it has to be taken from a guardian with authority for restrictive practices. And that goes back to that earlier slide that I was talking about, that for restrictive practices, often this needs to be done through a legal guardian. A person responsible often isn't quite enough when we come to restrictive practices. And if the restrictive practices are used in an unauthorized manner, so let's say we prescribe some, I'll just make it easy and talk about a psychotropic for a second. If we use some diazepam, I prescribe it, it's not been authorized, then it's administered, then that should be reported to the Safeguards Commission, because it's not been an authorised use of that medication. So why does this matter to us as GPs? I think it's just understanding that this exists, because we will often be involved when we get given these lovely medication purpose forms to sign off. And the reason they have these is that, unlike in an average population, a prescription doesn't give sufficient authorization for the service provider, so a support worker, residential care facility person, to administer that medication for a chemical restraint. They have to obtain authorization before they administer it. So it's actually an issue for the support workers under NDIS regulation. It's not really anything to do with our prescribing, but we often get involved because we have to explain why we're prescribing the medication. And annoyingly, we often have to get involved when it's been prescribed by someone else, like a specialist, and they haven't done this form, and then we have to do the form, which is a whole other contentious topic, which is annoying. So yeah, it's just to kind of make you aware of this, because you may come across this and you may not even be aware what a restricted practice is. It's very much talking about people in a supported independent living accommodation who have support workers that administer medications for them, or who are possibly even living in their own home but having medication administered by support workers through NDIS. It probably doesn't really have as much issue with people living in a private home setting with their family, because again, we consent them much in the way that we would anyone else. And again, why is this relevant for the pill or for contraception? Because If that contraception is used to purely manage behaviours of concern during their menstrual cycle, to reduce behaviours of concern, and it's not used for any other symptomatic relief or any contraception, then that is a restrictive practice. If the contraception is used for symptomatic management, like we talked about, so primarily the reason we're using it is because they've got dysmenorrhea, they've got menorrhagia, their epilepsy is worsening, then that is not a restrictive practice. So we can absolutely prescribe as much as we want for dysmenorrhea, for contraception, but if it's purely for behaviours of concern and that an NDIS sort of cared for person, then it is a restrictive practice and it will need to go through those processes. And then finally, which will leave us a good amount of time for questions, just some other considerations. So as with everyone else, we need to recognise that people may have a different sexuality, or they may identify differently, or they may be transgender. And the reason this is important is because it does influence our screening. So it influences our screening choices with cervical screening or prostate screening. If they're outwardly presenting as a different gender, we may not realise that they need cervical screening or prostate screening, and we should be asking about that like we would with our other patients. And also with sexual health screening or access to those extra medications we talked about PrEP before, for example. So I think just sort of being aware and again, asking about it like we should be doing, but in this population, often it just isn't really done. I think just being aware that our approach to this whole topic may be different for our Indigenous populations. So obviously, there may be culturally different ways of discussing about sex in those populations. They may, not be more as comfortable as discussing it. There may, it's not ideal to be discussing that with a woman in front of a man, for example, in some cultures. And I think also just recognizing that Indigenous people with intellectual disability are a marginalized group within a marginalized group. So their access to services is even more kind of restricted than normal. And because of, the generational trauma, they may, again, not actively seek medical support and medical help. And we need to kind of try and make that environment as comfortable as possible to kind of open up those conversations and foster that relationship and encourage regular reviews. And like with our other Indigenous patients, we may need to be more flexible in our approach. We may see them and then not see them for a long time, and that we may just need to kind of go with the flow a bit with those people. And then, as I touched on before, we have to be very aware that this population are at extreme risk of sexual abuse and violence. So data gathered in the recent Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability, which I think was around 2021 now, found that women with disability are nearly twice as likely to have been sexually assaulted as women without disability. So it's 29% compared to 15%. And since the age of 15, 45% of women with psychological or intellectual disability have experienced sexual assault, compared with 29% of all of those women with disability. So people with intellectual disability are far more likely to be sexually assaulted than just people with disability. And they are far more likely to be assaulted than people without a disability. And I think those statistics are really, really shocking. But when we talked earlier about cervical screening, that just shows how much we need to be offering these things, because we might not know this is going on in the background or has gone in the background. And as I said, their family members may not be aware of it. So we have to kind of consider that this is in the background. And a lot of these people will be carrying trauma. If they have been sexually assaulted, understandably, they're probably going to carry some sort of trauma around that. So we need to be approaching these conversations in a very trauma sensitive way. We need to be aware that invasive screenings may not be tolerated, or they may find very, very difficult. And again, I think just being flexible in our approach and just being aware and approaching these things in a sensitive manner, so that we're not further traumatizing these patients. And that is it. I will stop talking now. I realize I've talked a lot at you. I'd be happy to answer any questions, or just if there's any discussion points or anything anyone wants to say. Thank you very much.
Thank you so much, Jessica. That was amazing, so comprehensive, and an area that we often struggle with. And I like your little tips about with the health assessments, making sure we ask about contraception and sexual activity, etc. I might start off with a question while we wait for people to put their hands up. What about the issue of, like, I suppose, sterilisation? Really.
Yeah, I haven't really covered that because it's something that I personally haven't really come across very much. And I think, again, I think it's similar to what we've covered in the talk, really. I think it's very much of, why are we considering that? You know, is it because the risk is so great that this person just doesn't understand and is just having lots of unprotected sex, and and the pregnancy risk would just be too great for them? I think for something of that magnitude, if that person isn't consenting, then I think that should really be sort of taken up to those higher echelons in terms of the guardians, because I think that's obviously oftentimes an irreversible treatment. And I think we should be exploring all of the other possible avenues before we kind of reach that level of conclusion. Obviously, if the patient is wanting sterilisation because they don't want to have children, or we've fully consented, then I don't think there's any issue with that. But if it's being made for them because of their behaviours, then I think we need to really, really consider, is that appropriate, and have we fully explored everything else first? Yeah.
And it's Depo, I remember years ago, and I think it was when I was a registrar, there was an issue with Depo-Provera sort of being put into that sterilisation category because it caused delay in return to fertility. And so you had to go sort of through the guardianship board to get permission for that. Is that still the case, or can Depo be used a bit more freely?
Not that I'm aware of, but I think you would just have to be making sure that when you're gathering that consent, whether that be from the person or from the consenting parties, that you would have to explicitly explain that. Again, I think Depo is just being used less and less nowadays anyway, to be honest, mainly because of the side effect profile with it. You know, and I think, you know, the bone density issues, and I think, I just think it's just kind of being phased out a bit, to be honest.
Yeah, no, that's great. And Dimity.
Hi, and thank you very much for that really comprehensive talk. It was really interesting. I just wondered what the process would be if there's been an incident of sexual abuse for someone with disability. I'm thinking of a patient of mine who years ago was attending what we called them sheltered workshops in those days. I'm sure they've got a different name now. And he came home, and his parents were convinced that he'd been sexually abused, and they did talk to the place, and something had happened. But what are our obligations there, given he actually couldn't communicate very well about exactly what it was, and so on and so forth? Yeah.
So I think the process that I'm aware of is going through the NDIS safeguarding commission and reporting it that way. So if there's any concerns that there's an abuse occurring, then it needs to be escalated up to that authority if they're an NDIS provider. If they're not an NDIS provider, I think it goes through the kind of adult facts equivalent. I can't remember where that is off the top of my head, but I think it goes through there. And then, of course, obviously, there's the option of reporting to the police, depending on if the person or the family want to report that. So it kind of depends who the organisation sits under. But if they're an NDIS organisation, then it goes through the NDIS Safeguarding Commission, and they then investigate it. They're responsible for investigating. And I don't think it necessarily needs to be a person like ourselves. The family could report that, for example, as far as I'm aware.
Yeah, the Safeguarding Commission. Thanks very much for that. That's good.
And Timothy, I know with my work I do sexual assault forensics at the hospital, and certainly, those with intellectual disabilities are a vulnerable population, and I've had to do quite a few forensic examinations, and it's a little bit tricky with consent, but and history, but we do, take forensic samples, and certainly it goes further on occasions. So
it's okay to refer them to you.
Yeah, like if you could actually, if you're suspecting, you could actually just send them to hospital. Then they'll be seen by social work, and then decide whether to get police involved, etc. And usually, it does require a phone call to the guardianship board as well for consent for examination as well for the patient.
And you'll do all that. That's fantastic. Thank you.
Yeah. Any other questions? And I was just thinking a great topic for a future presentation, Jessica, would be on just health assessments in intellectual disabilities, because that's something that we don't do enough of. Like we do the 75 health assessments.